welcome to all of our viewers here today. I'm Kristen Schwartz, licensed midwife and one of the MCs here at Gold. And today I'm chatting with Jola Berkman. Hi, Jola.
Hi, Kristen. How are you doing?
Good. It's so nice to have you here. Jola, of course, you are one of our presenters for our Gold Neonatal Online Conference here of 2024. We get started just around just around a little while here in June. And we want to talk about your presentation. And the title of your presentation is Implementing Eat, Sleep, Console, Improving Outcomes for Substance-Exposed Infants. Very important topic. But first of all, tell us a little bit about your professional background.
I am a NICU nurse by background. As you can hear from my accent, I am from South Africa, so that's where I did most of my training before I came to Canada. Really, babies has always been my passion. And then more than that, when I came to Canada, I also started learning about newborns that were exposed to substances during their pregnancy and how to manage these babies to give them the best possible outcome as they go further in their life. And I think that happens at birth, and the first week after birth is where we can start setting them up for a good outcome.
Fantastic. Wonderful. And this is what your presentation is also going to be about. I feel like, and correct me if I'm wrong, but I feel like we're living in a mental health crisis, especially after the pandemic. Do you see an increase in substance use and babies in the NICU with that?
There isn't,
Yes.
yeah, there is certainly an increase of people diagnosed with substance use disorder and maybe also with pregnant people with substance use disorder, though I don't think our numbers has changed that much in BC. We've been pretty stable. We always had a higher incidence than the rest of the country, but we've actually gone down compared to the other provinces, which has gone up. But I think the complexity of how the babies are experiencing substance exposure is different, and that also complicates their withdrawal. And that's certainly been different, and that's to do with the toxic supply of substances out there.
Yes, absolutely. And when I learned a little bit about your presentation, I'm so thrilled about it because I feel like with regards to this topic, we have come a long way, or we're getting there, right, into a kind of a new era of implementing Eat, Sleep, Console, and explain a little bit of what that is and how this is different and how babies in the NICU with NAS have been treated in the past.
So in the past, these babies were always regarded as sick babies. They needed to be in the NICU. That was based on the previous evaluation or assessment tools we had, and also just the attitude, general attitude towards pregnant people with substance use disorder. What eSleep Console is trying to do is to normalize the baby and looking at normal developmental milestones. Rather than going through all the signs and symptoms you see, let's see how the baby's functioning. Can the baby eat? Can the baby sleep? And can we console the baby? And then how can we integrate the mother or the rest of the family into the care of the baby? Rather than the nurse delivering the care, we get the parents or the family to deliver that. We need to be very responsive. If this baby's crying, we need to respond to that. So we're trying to change it from a baby that's sort of admitted into a NICU as a sick baby to normalizing this baby. These babies should not be in the NICU unless there's another indication for that. So it is my hope is that this will be one of the last times I have to present on this topic at a NICU conference. Rather, it should be at perinatal and postpartum. Nurses should learn about this because that's where they belong with their families as much as possible. So that is really the emphasis of Eat, Sleep, Console. Let's normalize it and let's see how they function as normal babies and where can we support them to be normal in their functionalities.
And that's a huge shift. I'm so happy to hear that because, you know, it's a whole different lens we're looking at these babies in care then. Absolutely. So tell me a little bit about that. What have you seen over the years as success stories? And I think it also looking at the baby, but also at the family, at the parents, right? I mean, there must be also a huge shift in also how care is perceived and also how they can be involved in the care. Before this baby, as you said, was seen as a sick baby, I can see also some guilt, shame, blame going around there, right? But if we're shifting this now into this is a normal baby and we're doing things completely different involving the parents, how can that also how is that shifted and what have you seen?
It's been a slow shift. I think e-sleep consul's been going since 2008 in small areas in the States, and then they try to sort of grow it from there. But there's been this sort of stigmatizing of the pregnant people with substance use disorder. And that's probably the biggest shift rather than just how we're managing the baby. But it is a slow shift, but it's happening. I've certainly seen an uptake in BC. And it's organic. Not all our sites are doing that, but they are doing parts of that. And even across Canada, it's shifting. And most people feel that they are empowering the family and the pregnant person and the newly parenting mother. They are empowering the family to start actually participating in their baby's care. And we sort of try to tell them they're actually the first line of medication for the baby rather than us taking over and giving the baby medication. So that shift is happening, but it is a slow shift because there's a lot of adjustments that need to make. And I think the complexity of substance use disorder is definitely a barrier for some people. But we need to get through that because these babies do deserve better care than what we used to give to the babies. So it's we can measure the outcome on the length of stay. That's definitely decreasing. The amount of morphine that we give is definitely decreasing. And more importantly is that we hopefully seeing, and we are seeing it anecdotally now, less babies are going to foster care. They go home in the care either of their parents, and if the parents are not healthy enough yet, then into family members' care, which I think is a huge advantage to prevent any toxic stress and potential epigenetic changes that can have lifelong effects on the baby's health.
That's wonderful that you're saying that. Absolutely fascinating. Thank you so much for sharing that. You talked about barriers, slow shift. I can also see some barriers of implementing this in hospitals because we like things the way we always do them, right? Change is always hard. So talk a little bit about that.
The changes is hard, and I think when most of us used to use the Finnegan assessment tool, and that was a very sort of tabulated tool for check boxes, and nurses do like that. Physicians like to see the weighted numbers we give to them, and now we're asking them to be more intuitive and how they're going to assess the babies and support the babies. That's the one shift. The other shift is actually recognizing diet care as probably the most important tool. Because again, as part of the stigmatization of people with substance use disorder, are we really going to entrust the care of this baby to the mother if she actually is still actively using it? There's a lot of complexities to that question because not all of our mothers would be on methadone or on another OAT. So these things are all barriers that we'll see. We need buy-in from management, from leadership. Often they think there is a dollar value that's going to increase, which is shown over a few good studies already, is that our costs are decreasing, although maybe it go up first until we know how to use the system. Then after that, it's cheaper. A lot of people will tell me again, another barrier is they haven't got enough staff because these babies now would be one-to-one nursing. Again, the research are showing that that is not the truth. So there's all these barriers, and it's for us to actually give people solutions to the barriers, and how can we overcome that again to try and give, because it's our responsibility to give the best possible care to these babies before we send them home.
Yeah, give the best possible care to these babies before they're going home. Well, thank you so very much, Jola Berkman, for spending time here with me and talking about the wonderful presentation you have lined up for us here at the Gold Neonatal Online Conference. Thank you so much.
Thank you. I'm looking forward to it.
And now some information for our viewers. If you are interested in this presentation, implementing Eat Sleep Console, improving outcomes for substance-exposed infants, and all the other wonderful presentations that we have as part of the conference, we invite you to go to goldneonatal.com. We have an open access keynote presentation available for you on June 3rd with Dr. Niels Berkman. And I hope you will not miss this beautiful presentation. As I mentioned, it's open access and free of charge. So make sure you sign up, reserve your seat, and I hope to see everyone at the conference. Thank you, everyone. Bye-bye.